Here are my conflict of interests disclosures. I was also asked to discuss recommendation 50 as it applies to some of the work that we've done. So recommendation 50, I'm not going to reiterate, but you all know that now the management of thyroid cancer may be also dependent on TG levels, stimulated TG levels at the end of the day. So how do we manage these patients post-op? Well, TG, ultrasound, and sometimes whole body scanning. So TG and ultrasound is what we do in our center. And then we can classify these patients according to their risk. And in fact, we can also risk stratify these patients according to their strata. And it's interesting that patients with biochemical or structural problems don't fare as well as those patients with excellent responses. So this risk stratification kind of works. Now, I was asked to just comment on how patients are managed post-operatively, and I think pretty much across the board now, most patients with well-differentiated thyroid cancer, and even not well-differentiated, are investigated by their clinical presentation post-op, serum TG, and structural imaging, ultrasound. And when those patients have some abnormality, that sets up a cascade of events, usually imaging, in order to investigate why they have those structural or those biochemical abnormalities post-op. So in Toronto, we looked at this and we felt that this was kind of non-specific because it was based on a number of clinical factors in managing these patients post-op. So we wanted a metric to hang our hat on. So here's a paper that was published recently about the utility of serum thyroglobulin, and you can see the negative predictive value in using TG is quite high. So as I said, the limitations of the current guidelines are that they're based on clinical factors, and there is no metric heretofore that we've hung our hat on. So again, recommendation 50, as Steve has alluded to, we looked at 129 patients to be exact, and here were the entry criteria for these patients. Basically, they were low or intermediate risk patients according to the ATA guidelines, and all of them underwent a total or a completion thyroidectomy, and you can see what their biochemical parameters were. So here are the demographics of our patient population, and you can see that there's a good smattering across the breadth of the classification of thyroid, the TNM classification of thyroid tumors. Here are the stages of those patients. You can see that most of them were low risk. There were 9 patients who were at intermediate risk. And here is the algorithm that we use. So just let me spend a minute going through this. You can see that we divided the patients into 3 groups. Patients who had a stimulated TG of less than 1, those that had 1 to 5, and those who had greater than 5. And our decision about applying RAI was based on this. The intermediate group kind of fell into the middle group, and whether or not they had RAI were based on clinical factors. So here they are. And here is a diagram of the patient population again, and 65% were in the less than 1 group, 31% in that intermediate between 1 and 5, and only 5 patients in that greater than 5 group. There's a typo here. 1 patient refused RAI out of the 84. 8 patients in the intermediate group received RAI, and one patient actually refused in the high group for personal reasons. I'm sorry, 1 patient had RAI in the low group, and 1 patient refused it in the higher group, and 8 patients received it in the intermediate group. So I can tell you that None of these patients, save one, recurred. I operated on that patient. That patient's still alive. We now have 8-year follow-up on this group of patients, and except for that one patient, no patients recurred and no patients died. Now, if you apply the ATA guidelines to that clinical cohort, 57% would have received radioactive iodine. In our patient group, only 10% did. So now we have this metric. This strategy avoided routine remnant ablation. It avoided radiation as potential acute and chronic complications.